Hey guys, it's Dr. S. So what I want you to do is go to Module 1 and pull your medication template for should be either listed individually or within class resources, but it's individual, I'm pretty sure. I'm doing a voiceover for Modules 1 and 2 meds. We don't have time in class to decipher um, common side effects, nursing considerations, patient teaching, and monitoring parameters. So we're going to add to this document to align with pharmacological management for renal calculi, um, BPH, and pain management postoperatively for TERPs related to BPH, T-tubes put in for renal calculi removal, things of that nature. Um, so you can pause me and then get your document. You can write on it. Obviously, this is testable material. Um, so we're going to start with hydromorphone. We already know the common side effect is respiratory depression. Some things that might be helpful for you, obviously we did Dilaudid in 117 as a medication template. So I do know we're doing different medication templates. At least the template itself is an Elsevier template compared to a different template that pharmacology used. Um, so we do have to redo it, but we can step it up a level. And now you can capture more specific data than all the material that you didn't know what you didn't know, and you wrote everything that was there. Also, by doing things bolded or capitalized lettering, such as uh, I forgot the name of tall lettering for medications that look alike and possibly sound alike. So with the Dilaudid, we've already talked about the fact that the mechanism of action, indications, and the class is already provided for you. So we talked about in class being primarily a CNS depression, or the way that it binds to the pain receptors in your brain is to change the way that your brain perceives pain. So with that, it causes CNS depression. So in addition to monitoring respiratory rate prior to, during, and after, which is your evaluation component or part of this medication administration, you also want to be sure that with CNS depression, we understand that patients um, can have lethargy, be more fatigued, more tired. You can have, especially with your older patients with underlying potential of dementia and Alzheimer's, we should use it cautiously nonetheless. You can have some forms of delirium or increased confusion. It is considered higher alert, but probably, well, not probably, but because of its addictive nature and the way that it changes the way that patients receive perceive pain based on how the brain adapts to it, and can cause euphoria as well. It can cause feeling elated, and that can be addictive properties for patients in general, people in general. Um, it can cause hypotension. So safety is a big thing, making sure call bell, side rails, bed's lowest position as possible. Definitely constipation because it kind of slows everything down, hence the word CNS depression. So it slows the body down. So depression can cause the constipation. So sometimes it's helpful to be on stool softeners, increase fiber, increase fluids, increase mobility. Nausea, so based on whether you can take it with food or not, for pain management. Any type of opioids, mental health medications, cardiac medications, a lot of your, I wouldn't say high alert, but a lot of your patient education is going to be do not drive or use heavy machinery until you know the effects of how the med's going to affect you, especially mental health meds, cardiac meds related to vital signs, blood pressures, heart rate changes, hypotension, bradycardia. So we don't want people making any type of really serious life decisions, and working with any kind of tools or anything that can cause harm, because we haven't worked out how well the dosage works for the patient and how well the patient is or is not responding to it. Um, we've already talked about the nursing considerations. You definitely, your biggest thing is keeping an eye out for your respiratory rate and patient safety. Um, pain you're reevaluating, and I talk about subjective versus objective. So objective is the pain scale. And you would see doctor or provider orders like 7 to 10 is severe pain. Well, we have to have some parameter for severe pain. So that becomes an objective assessment by your provider, putting in there that we can give X number of milligrams for this medication if the patient states their pain is 7, 8, 9, or 10. So it gets a little bit workaround. What's your antidote for Dilaudid? Okay, that was a medication you did in module or week 2 for your 117 lab, and that's naloxone. So patient teaching, what do you think? So if it's causing CNS depression, what specifically do we want to teach our patients not to do? We already talked about the driving and the heavy machinery, making important decisions or not to make them, but avoiding anything that's going to exacerbate CNS depression. So what does that mean? Avoiding alcohol is one of them. Specifically, it's going to cause fatigue, it's going to cause tiredness. And so avoiding alcohol, and then the things we talked about, safety with driving machinery, things like that. So in addition to monitoring respiratory rate, what is the other composite of that focused assessment? Listening to lung sounds, pulse oximetry, even if the respiratory rate, say, is 14 and they stay 14, but are they taking big, deep breaths? Are they getting enough oxygenated perfusion throughout? Or are they sitting in the low 90s but have a good respiratory rate? Remember, hypoxia is low oxygen levels in the bloodstream, and we have our carotid arteries that feed oxygen to our brain. So folks on any form of opiates, and the older we are, the more susceptible we are, or can be susceptible for more enhanced side effects like a lower respiratory rate or an increased confused state. Or poor judgment associated with age as well. So remember, level of consciousness, blood pressure is very important, hypotension, constipation, respiratory rate, and reevaluation. So you always want to get a full set of vital signs, in my opinion, before you give patients any medication. Now, some students have said, well, I got the 7 o'clock vitals, but I'm giving a blood pressure medication at 9 o'clock. Okay. You're going to go with the CNA 7 o'clock vital signs, or do you want to get your own? Or do you have a team of CNA staff and other nurses that you are comfortable saying to the CNA, can you grab a set of vitals? Because I have to give 9 o'clock meds and they have blood pressure meds. Or do you go get your own? So think about those things. 2 hours is a big deal. Okay. So it's not always the most accurate assessment. And the same would also be for respiratory rate. The next medication is ibuprofen. I didn't neglect so much, but there wasn't enough time in talking about the things we talked about on our first day. NSAIDs, your global classification was also part of your medication template in 117. There is a new black box warning that has stipulated or come out, and you will see it if you're buying Motrin, Aleve, Advil, etc. on the market over the counter. Black box warning is to be extremely more cautious now with folks over the age of 60 because of the increased risk for peptic ulcer disease or development of kidney failure, kidney injury. Because if you exceed the daily dose of Motrin to manage chronic pain, for example, you do run the risk of having problems with kidney function. And you know the labs that you would have to draw or make sure the provider has drawn prior to giving any medication, regardless of direct impact on the kidney, such as NSAIDs or ACE inhibitors for blood pressure, etc. So your biggest nursing consideration is GI irritation and GI bleed, as well as the renal impairment, as I noted. All right, so we want to give it with food. We want to make sure we're avoiding any anticoagulant medications. And if your patient has a kidney disease, such as they're on dialysis, they're not on NSAIDs. I mean, if they are, then that's a serious provider problem. So if they're chronic kidney disease, on dialysis, in the process of an acute kidney injury, remember acute's resolvable, less than 3 months, less than 6 months, whatever resource you use. So be mindful of that. You do not want to take multiple different kinds of NSAIDs. So Aleve and Advil together, Motrin, Aleve together. Even though they're NSAIDs, they're still within the classification. So when I said in class about a medication classification such as NSAIDs, the prototype for us would be ibuprofen. So you have one medication in the huge umbrella of all these meds that fit under what these medications do, and we're focusing on the ibuprofen or Motrin. So bottom line is risk for GI bleeds, risk for renal impairment. So when you think about your populations, who should not be on the NSAIDs, okay? Because of the risk for GI bleeds, even if one of the things of having peptic ulcer disease, even if a patient has a diagnosis and they're managing the chronicity, once even one ulcer heals over, you can still develop another. So that's why I stress with the MARS or the reconciliation of home medications, if they're on Prilosec, Pepcid, or they're getting a prescription for omeprazole, then they're having an issue either with GERD or peptic ulcer disease or a combination of both. So if they have an NSAID listed, that's a big fat no-no. And we have to get at to why, because they're just increasing their risk. Remember that your red blood cells carry iron and oxygen. So folks with internal GI bleeds, and I don't mean something that's turning into a hemorrhage and a full coat or rapid on the unit. People can be in a slow bleed, if you will, over time. And one of the ways that we would look at that is to look at the stools, because when they start vomiting blood, that's a whole different scenario. But if you have black tarry stools, especially if they're on iron replacements, the iron is going to cause the stool to be black and tarry. So just think about how we can teach patients about anemia, how it relates to fatigue, shortness of breath with activity, with no respiratory compromise, pale skin, cold, needing to be warm. Those things can trigger us to really maybe do a CBC and get an H&H and look at red blood cell function. So that's kind of a workaround, if you will, to getting a little bit more information on that. The next medication is Proscar, and that specifically is going to relate to your BPH. So basically what it's doing is we're using it for prostate cancer to help reduce the growth of the tumor related to testosterone. So it's by blocking that conversion of testosterone that the prostate cancer, the cancer cells, when they change shapes from benign to malignant, the cancer itself feeds off of the testosterone. So when you introduce Proscar, for example, you're blocking the testosterone to a chemical called DHT, and that will help decrease the prostate size. You can also use Proscar for BPH, benign BPH. I do hope that my pronunciation gets better over time. So you will see people on Proscar as well as Flomax for BPH and or prostate cancer. But one of the common side effects that will affect, I hate the word compliance, but that will affect your patients, male patients, from using this, especially if their diagnosis is early in reproductive time, they're fertile, even if they're over the age of 70. I mean, psychosocial sexual intimacy is a necessity in life to not feel alone, to be in the company of others, to have physical contact. It's part of Maslow when you really think about it. But Proscar decreases libido, which means kind of decreases the not wanting to, not interested. So you're not interested in having intimate relations with a partner. It also can cause ED, which that can affect body image, that can affect how a person views themselves. It can have huge psychosocial side effects that we have to teach the patients that. So we hope they don't stop taking the medication, because it can be detrimental to them if they suddenly stop. This is contraindicated for pregnant women, should not handle this medication at all. And if by some chance that the medication got crushed or broken, it's not to be used by the patient, because it will lower, it's just don't handle crushed tablets by the pregnant people at all, women in particular. But hopefully by being on a regimen of Proscar, and it depends on the provider and how often they're going to redraw the PSA, because you're keeping the testosterone from converting with this medication. So the hope of the medication, the expected outcome, is to decrease the PSA levels. Okay, patient teaching. It's not an overnight fix. So usually PSAs are done on an annual basis as part of routine management. So if a patient has started on Proscar, it's going to take months to see a reduction in PSA levels. So it may be a 6-month return for redraw. It may even be a year down the road. It's all going to be provider choice and patient presentation. But because of the changes in how the testosterone is utilized, the male patient may have changes to their breasts. And that means that this, I think it's called gynecomastia, which actually might mean that the breasts start to enlarge a little bit. So they may look and have concerns about reshaping of the breast tissue because men do carry estrogen and progesterone. It's just more testosterone for the male functionality of sex hormones. But when you're decreasing or changing how much testosterone's in the body, you may see a flip in the hormones where there's more production of estrogen, and that may show breast changes. That's also can be a huge psychosocial determinant for your male patients as well. And do not donate blood while they're on Proscar. So we're monitoring parameters, urinary output, of course, because of the obstruction that the hypertrophy of the prostate can cause. So we still have to monitor all the symptoms that we talked about in class, and the PSA levels, depending on how the frequency of the physician wants to draw that. The next medication is Flomax, and what that does is relax the smooth muscle within the bladder neck. So when I kind of did this in class, you have the bladder, then you have the little piece of the neck, and then you have the ureter. So when you insert a Foley catheter back in your 111 days, you want to go past the bladder neck and into the bladder. So as you inflate the balloon, so the catheter doesn't fall out. The balloon is above the bladder neck to hold the catheter in place. Because when you know about the balloon, it circles around the catheter. So the catheter is still in the bladder itself, but here's the balloon and the neck is here. So what the medication does is relaxes the bladder, smooth muscle of the bladder and the neck. So it increases urinary output, okay? You don't have the spasms associated to it. It relaxes the prostate muscle as well. So it's to improve urinary output. But it has a cardiac side effect that's very common, and that's orthostatic hypotension. Now, when you talk to me about hypotension as it relates to, bear with me, I'll find it in a second. Dilaudid, that's hypotension, okay? Meaning a lower blood pressure with activity, pardon me, or at rest. Orthostatic hypotension is specific changes in positions that causes your patient to have low blood pressures. So you have them laying down, supine, and then you sit them up and you wait. I think the researcher Elsevier may say 5 minutes, take their blood pressure, and then you stand them up. Now, if they're orthostatic, that blood pressure will drop at sitting and it will drop even more at standing. That increases your risk for patients' dizziness, syncopal episodes, and falls. And as we get older, we don't want to fall because hip fractures in general have a higher morbidity level in older patients. So one of the ways we can decrease orthostatic hypotension is give it at bedtime, so they go to bed. So now I can hear some of you say, well, wait a minute, what if they have to get up during the night because of the nocturia? Urinal, best case scenario, urinal or bedside commode, especially at home, not in the hospital. And you want to watch them really closely for that first dose because as you learned in 117, medication initiated as a first dose always requires monitoring of the patient to see how they are responding. Okay, we'll talk a lot about response to mental health medications when we get there. So obviously you know the drill. Again, don't drive for the first time on this medication. We don't know what it's going to do to your blood pressure. Obviously you want to rise slowly and change position slowly. And report immediately any dizziness to the provider that prescribed the medication. It makes sense when you think about hypotension and the safety measures that have to apply to that. And so the parameters are you're monitoring the blood pressure and the urinary output. And hopefully they're having some symptom relief. So less nocturia, less dribbling, less urinary hesitancy and frequency. All right. Last but not least is acetaminophen or Tylenol, non-opioid, so your anti-analgesic and pain reliever, antipyretic. It works in the CNS system, but it's not an opiate, so it doesn't cause CNS depression. And it's a lot safer than NSAID, even though it's not an anti-inflammatory. But the biggest problem with Tylenol is the possibility of what's called hepatotoxicity, which is liver damage, with long-term exceeding the recommended daily allowance of the Tylenol can cause over time liver failure or cirrhosis. So when you talk cirrhosis in 211, it's just not driven to alcoholism. So we have to remove some of that stigmatism and the barriers. We can have liver cirrhosis from fatty liver disease. We can have cirrhosis from hepatitis. We can have cirrhosis from overusing of Tylenol. So make sure you're broadening out your patient populations and not just associating cirrhosis to alcoholism. So make sure that we're teaching the patients about how much Tylenol they can have on a daily basis. And though they haven't put out a black box warning yet for folks over 60 with Tylenol, I'm pretty sure it's coming down the pike, and it'll always going to say use cautiously with folks who do drink alcohol. Other parameters specific, you already have a bad liver, pardon the expression, or you're over the age of 60. Because as we get older, our digestive process slows down, everything slows down. So we're more likely to hold on to medications in our system because we're not excreting as well as we did in our 40s, 30s, and 20s. Same thing for our liver for metabolism. Sometimes Tylenol will be combo medications, which is another component of your 117 days, where Tylenol and another medication are together. I think you see like Tylenol PM, for example. So maybe there's a sleep additive with the Tylenol. Be very careful that we're explaining to folks that this is not always a good thing, and then trying to get at to why they're taking combo medication. Can we get that baseline educational assessment from your patient? And remember, with liver abnormalities, you would see the patient having some jaundice, like the sclera, the yellowing of the skin, elevated bilirubin levels in blood work, elevated ALT and AST. And if they do a urinalysis, you may see them spilling bilirubin. Obviously, these folks should avoid alcohol in general, and they might have right upper quadrant pain. And as I said in this past Tuesday or Module 2 content, laying them flat. If they have an enlarged liver from an inflammatory process, you'll be able to feel the liver on palpation. Okay, that's going to take care of your renal calculi, BPH, and prostate cancer. So go ahead and pause me, go to Module 2, pull the med list there for peptic ulcer disease, pancreatitis, and gallbladder. All right, so when we talk inflammation, we're talking an inflammatory process. So outside of your NSAIDs, which are over the counter, you also have another group of anti-inflammatory meds called steroids. And within the family of steroids, you have several different kinds, prednisone, deltazone, etc. So again, the suffix of your zones, your SONEs, are very critical in understanding glucocorticoids and corticosteroids. Steroids in the body that we naturally have. And I do pronounce so much better than I am right now, but our body has natural steroids in our body. So when we add pharmacological management steroids over prescription wise for an inflammatory process such as bronchitis, an exacerbation of COPD, an inflammation of rheumatoid arthritis, anytime we need to decrease any forms of inflammation or swelling that's causing a problem with whatever that organ system is from functioning. So it not only does it decrease inflammation, but it suppresses the immune system. And so our immunity is responsible for helping us in a healthy body ward off infections such as even the common cold, getting the flu. As we get older, avoiding community-acquired pneumonia or CAP. Getting our shingles vaccine, getting our RSV vaccine, which used to be just for pediatrics, but now they're recommending it for folks over the age of 55 who also might have a smoking history or respiratory disease process, that they need RSV, because your lungs are weak enough to begin with that you're more susceptible to a lung infection. So we have to be very careful when people could be on long-term prednisones, for example. Your COPD patients may be on bronchodilators that have steroids. They may be on steroids by mouth continuously. Their immune system is always going to be compromised. So these folks are the kind of people that should be wearing masks in public and in large groups, should avoid fresh flowers and fresh fruits, just because you want to keep the natural bacteria that comes on flowers and fruits and vegetables needs to be properly washed, to ensure that, because of our poor immune system, we're at risk for what's called adventitious or opportunistic infections, where the healthy person's not going to have that happen. Prednisone can also cause increased blood sugars on patients who aren't diabetic. And so we have to make sure that we are monitoring not only the effectiveness of the inflammatory reaction. For example, labs, is the ESR and or CRP lower than the baseline being elevated in the first place? Does the patient have a temperature? What is the white blood cell count? While I'm on the subject of white blood cell counts, you have what's called a CBC with differential. That means that we take in the white blood cell count and we're looking at all of the white blood cell family. So leukocytes, neutrophils, eosinophils, basophils. So looking at how well the white blood cell family exists in numbers in the body is a very good parameter for someone's immune system. Leukocytes are considered old warriors, and neutrophils are considered new warriors. So when someone has a new infection, they're going to have an elevated neutrophil level. And you'll learn what's called left shift neutrophils when you learn about appendicitis. And leukocytes elevated means an old infection or an old inflammatory chronic disease is an exacerbation. COPD is an example. Rheumatoid arthritis is an example. So common side effects is hyperglycemia. So these folks need to have their blood sugars. You can gain weight with prednisone. As I said, they're at risk for infection. Mood changes, and osteoporosis. Osteoporosis is typically postmenopausal, but men can also lose calcium. So over the years, we're supposed to eat lots of good calcium-driven dietary products, and our bones naturally store calcium. But once we go through menopause, for whatever hormones happening, the calcium is released from our bones. So now our bones are hollow. So when we fall, we're more likely to break something, and that's called pathological break, or it could just break on its own. Just means it cracks on its own. You haven't fallen or caused any trauma. It's just weak, and it just breaks. All right. You want to make sure they take it with food. Don't taper as prescribed, because you don't want to cause what's called a rebound hyper or hypoglycemia. So if you're taking what's called a 5-day pack, you follow directions, you teach your patients accordingly, so you don't have rebound glycemic issues. So what do you think your parameters are? Monitor your blood glucose, weigh the patients, assess for mood changes, teach about infection control, wearing masks, etc., monitoring their temperature. All right, we already talked about Dilaudid. Morphine is also an opioid, opioid, falls into the CNS category of relieving of pain as well. We use morphine also for folks that are having chest pain that's not relieved with nitroglycerin, as well as someone who's having an active MI or myocardial infarction. Some of the things with morphine that's really fascinating is it decreases the heart's muscle need for oxygen, and therefore by doing that is decreasing the chest pain activity. When the heart doesn't need that much oxygen due to giving them morphine, they have less chest pain. So it's a great additive that morphine has, that chemical derivative. Dilaudid does not. So of course, respiratory depression, hypotension, constipation, etc. So it's highly addictive. Any opioid is highly addictive. Morphine can also be delivered sublingual. Sometimes it's used in hospice cases as well, especially end-stage congestive heart failure, because less demand of oxygen on the heart will cause this heart to relax and can promote a peaceful death. And so you will see it used sublingually in hospice care if that's something you choose to practice in. So obviously your parameters would be respiratory rate, blood pressure, level of consciousness, and pain level. Omeprazole is going to be a medication that we talked about with peptic ulcer disease, GERD. We have another genetic hereditary Zollinger syndrome, which I didn't talk about, but it's on your PowerPoint. That's a hereditary predisposition to hyperactivity of proton pump activity. So they're automatically a risk for PUD because of that genetic predisposition that the proton pumps just overproduce and over-excrete pepsin and hydrochloric acid. But what Prilosec does is it blocks the gastric acid secretion. So it's not inhibiting so much the pump, but it's blocking how much of the pump is releasing the acid secretions. It can cause a headache, it can cause diarrhea, it can drop magnesium and calcium levels. So your patients who are on Prilosec in the hospital have to have mag levels drawn. In the hospital, the level I think is 2.0, very small window, 2.20 to 2.34. They will get a mag transfusion at anything less than 1.8. Remember, magnesium is also a very heavy cardiac electrolyte for cardiac conductility, as well as calcium. So even though we talk a lot about potassium and sodium pump as it relates to kidneys, you have very powerful electrolytes such as mag and calcium as well, that are part of your vitamins, minerals, and electrolyte management of the small intestine as well. Long-term use can increase fracture risks and infection, but take before meals. The recommendation too, and I think it's also, you don't crush the medications, and usually your omeprazoles have to be taken separate before you start popping Tums or milk of magnesia, because milk of mag is magnesium and Tums is calcium. So when you're looking specifically at decreasing mag and calcium levels with Prilosec, it's going to offset things if you start messing around with magnesium and Tums. So it's just best if you take them separate. And part of it also, if your patient's popping Tums or drinking milk of mag like it's going out of style, they're putting a Band-Aid on a bigger problem, that the medication isn't going to work. They also put themselves at risk for hypermagnesium and hypercalcemia. So your parameters are mag levels and your calcium levels, and to assess the reduction of reflux, bloating, and belching. Because when you belching and burping, you're coughing, not coughing, that's not a good word, but you're bringing up of pepsin and hydrochloric acid, and that's eroding away the esophageal lining. Folks who are severe alcoholics will have what's called esophageal varices, and I think a student mentioned that in class. That's where your esophagus is bleeding because of the ulcerations due to alcohol, as well as belching and reflux. You're still bringing up acid from your stomach. So basically, you're just, don't crush the capsules. They should be taken whole. One of the things about Prilosec with long-term use, and I haven't validated it. It makes sense to me, but I'm not sure what chemical is driving it. Increases the risk for C. diff. Now, I did mention in class about good bacteria, since I think a student asked about probiotics. So we have good flora and bad flora, right? So if you're on an antibiotic for a long period of time, say vancomycin's classic, it's going to reduce not only the bad bacteria, which is supposed to fight, but it's generic. It's also going to take out the good flora. And that's what's predisposing people to C. diff, which is an opportunistic infection. So we really have to pay attention to long-term use of omeprazole, and it is over the counter now. So we give it IV push in the units at the hospital, and that's for people whether it's proactive to reduce stress-induced over-secretion of acids, or they truly, in fact, have an upper GI issue from peptic ulcer disease. All right, the next one is Tagamet, and that's one of those H2 receptor blockers I talked about. So without H. pylori, you got your twofold drug therapy, so a PPI and an H2 receptor blocker. This decreases gastric acid secretion. So not only am I inhibiting, now I am decreasing. All right, but this can cause gynecomastia, which is the word I was trying to figure out, which is breast enlargement. And it's specific to male gender. It's not specific to female gender. Can increase confusion in the elderly. and has multiple drug allergies or drug interactions. So we don't typically use it as much because of the amount of, so if you're a patient and you're reconciling home meds and they're on both of these, then it definitely warrants a discussion about confusion and the age of your patient who's taking it. Take it at bedtime, no smoking, no alcohol. So your parameters are monitoring mental status because of the increased risk for confusion. And your GI symptoms, are they, if they're using it by itself, for example, do they have decreased belching and burping? Do they feel less heartburn or esophageal burning? Pepcid is also an H2 receptor blocker, and that tends to be the drug of choice. So for prototypes for management, for testing, as well as what you see more or less on the streets, it's not a good question. When you see more or less in the MAR is going to be Pepcid and Prilosec. Tagamet is not commonly used as much anymore because of its drug-to-drug allergies. So this is the receptor blocker. Same thing, reduces or blocks histamine acid secretion. Folks can have a headache, dizziness, and diarrhea. It's the drug of choice over the Tagamet. So take as directed and monitor, make sure your outcomes of taking the med are reducing GI symptoms. Carafate is a mucosal protectant. It's like bismuth, it's like milk of magnesia, but you take it on an empty stomach and you take it by itself before other medications, because what it's supposed to do is coat the ulcer. So when you go to eat or take your medications, the ulcer is protected by this very thick viscosity of medication, and it's specifically for peptic ulcer disease, and it's a barrier. But you might have side effects of constipation. As I said, we're giving it on an empty stomach and you're separating it from other medications. Take before meals. There's no specific time frame. I would say at least an hour, 30 to 60 minutes before an hour. And if you are taking other PPIs or H2 receptor blockers, at least wait at least 2 hours or longer before you take the meds if you're using the Carafate. Should heal the ulcers over time. It's not an overnight fix, and we got to keep an eye on constipation. I'll talk about this later with UC and Crohn's. One of the major questions we'll ask patients is about their patterns of bowel movements, and that matters when we talk about colorectal cancer. So even though we talk to our patients about constipation, what is their baseline bowel pattern? Do they go every day, every other day, etc.? What does the stool look like? Is it round? Is it short? Is it long? What color is it? All of that documentation is absolutely critical when it comes to patients who have a history of constipation, and in addition to other inflammatory type diseases, and we'll continue to talk about next week. As the next medication I want to talk about is regarding pancreatitis. So from the digestive point, we talked about amylase, lipase, and pancrease. And so when the pancreas is in an autoimmune state and it's auto-digesting itself, you're going to have higher levels of these enzymes in the bloodstream. So when that happens, though, your pancreas doesn't have the opportunity or can function with its role of digestion. So if the pancreas gets bad enough, we have to provide alternate supplements so that when we're eating sugars, carbs, and proteins, or fat, proteins, and sugars, we have an overall medication that will help with the digestive process of these elements in our food. It's replacing digestive enzymes, and it's called pancreolipase. It's as I said, a digestive enzyme replacement for people who are in severe chronic pancreatitis, or have so many acute exacerbations secondary to gallstones, or even a viral attack or a traumatic accident that injures the pancreas directly. People aren't going to absorb fats, proteins, sugars, and carbs without this enzyme helping break down those food products as part of the digestive process. People can complain of abdominal pain, diarrhea, They can have hyper forms of uric anemia. I don't get too much into that. It's not as common as the abdominal pain and the diarrhea is. But it makes sense to tell you that they have to take this medication with meals because the meals contain the fat, sugars, the carbs, the proteins. So this medication is needed to break down those food components so that we get the energy, the sugar, the fat, and the carbohydrates to help our body function. So you're taking it with every meal. You want to report oily stools, which is sort of that fatty stool steatorrhea that I talked about, because that's not normal. That means we're not digesting fat, and we need fat as part of an insulator. Our brain needs fat to function. So we want to repeat that. Remember, clay-colored stools is lack of bile that's being blocked from the gallstone, and that's what's called clay-colored stools. So we're looking at weight gain. So the weight gain of your parameters is because by taking this digestive supplemental enzyme, the patients are getting the nutrition they need for their body to function, because usually chronic long-term pancreatitis due to alcoholism, people have weight loss because they're not able to absorb or process anything they put in their mouth when they do eat. So putting on weight, natural weight from food intake using this digestive enzyme to help that process is a positive outcome. And then, of course, you want to keep an eye on the stools. The other role we talked about with the pancreas is insulin production and release of insulin to manage sugar levels. So your type 2 patient, type 2 diabetics are more at risk for instability when they're in pancreatitis. But regardless of diabetic status, we have to check blood sugars on these folks, and we have to make sure that the physician or provider has ensured that we have a MAR with a sliding scale. So I want you to go back and I want you to pull your templates from 117 on your insulins. You should have rapid, short-acting, intermittent, and long-acting. And so intermittent is your NPH, your long-acting is Lantus, which is every 24 hours. Short-acting is typically about a half an hour to an hour onset after. Regular or rapid is 10 to 15 minutes. So I want you to pull that and make sure that you have that information. Some people with acute pancreatitis may not only just be on rapid insulin while they're in the hospital, but they could develop type 2 diabetes because of chronic pancreatitis. So they may not only be on sliding scales at the hospital, which you should expect to see, but they might be on a long-acting such as Lantus at home, which is given every 24 hours. So I just need you to bring those forward, because chronic pancreatitis as well as acute pancreatitis, gallstone etiology or alcoholism etiology is going to affect your patient's blood sugar, metabolic ability to function because of the assault on the kidneys, assault on the pancreas. All right, and with that, I am done. I will get this posted. This is testable material. If you have questions, make sure you ask, and I will talk to you all soon. Bye.